Thank you very much, Nikos, and also want to thank you all the organizers for this very kind invitation, and I want to congratulate for a beautiful center that you have, and most importantly for the efforts that you are putting in organizing a society of fertility preservation, which is such an important tool that we should offer to our patients. So what I'm going to be doing in the next half an hour, I'm going to give you an overview on the epidemiology of cancer, but also non-cancer, so medical conditions that may also require our service of fertility preservation. And if you want to read it in a different way, is also where to look for referrals, where are the patients. Then briefly on the risks of gonotoxicity, because I saw that even though the talks were in Greek, I think that there were some speakers this morning talking about the gonotoxicity, so very little on that. And then the barriers to access. We found the same problem in the United States as in Europe, and I'm sure even here in Greece, on how difficult it is to set up a service of fertility preservation, and why, even if you have the service, the referrals are still very little, very scarce. So that's in the brackets, why scarce referrals. And then how to set it up. So how to make the team that is going to be available to offer the service every day, 24 hours a day, 7 days a week, and what are the key elements for this. So let's start with the epidemiology. If you look at the United States, these are calculations that perhaps not very accurate, but give you a ballpark figure on how many potential cases of fertility preservation we, reproductive endocrinologists, oncologists, should be seeing every year. In the reproductive age, we estimate that 4% of all cancers per year are in the age group that are interesting for us. So about 55,000 women per year. Of course, you should also add the men to this, but today we only concentrate on women. And if you look at the type of cancer, 3,000 cervical cancer per year in the reproductive age, there are about 6,000 to 7,000 leukemia, lymphomas. The bulk, the great majority are breast cancer patients. And women that are in reproductive age, that they are affected by breast cancer, it's about 15% of all the breast cancer. It's about 40,000 per year. Now, to this you need to add other cases that are non-cancer, patients that they have a SLE, patients that they have a need for bone marrow transplant because they have a sickle cell anemia or any other type of conditions that are listed here. They also are part of the referral, the potential patients that they should come to have at least a consultation with a reproductive endocrinologist that talk about fertility preservation. And here you see thalassemia, sickle cell, aplastic anemia, because they are going to have a bone marrow transplant, autoimmune disease, lupus, thrombocytopenia, acute glomerulonephritis, base. So there are many situations, many conditions that they are going to be treated with the same chemotherapy that is used for cancer. And because of that, we should offer them opportunity for fertility preservation, and then add also risk of premature ovarian insufficiency for women that they are born with the Turner syndrome, mosaic, of course. Or patients with the recurrent endometriosis, the surgeon keeps cutting and cutting and cutting the ovary, is going to be left almost with none. Well, let's freeze some of those cortical tissue. Let's freeze some eggs. Let's freeze some embryos before the ovary is completely irreversibly lost. And now we are starting to see more and more patients that they are undergoing transgender body modifications. As you probably know, the American Society of Reproductive Medicine has advised reproductive endocrinologists not to have any discrimination and offering the service to a born boy that wants to become a female and a born female that wants to become a boy. And in fact, at the moment, we have done 2 cases where we have frozen eggs in a woman that is now going to become a man, and we freeze the sperm in a born boy that is going to become now gender operation in female. So those are things that are also happening, and that's also fertility preservation. Now, the risk of ovarian failure can be as high as 80% in patients that are exposed to high dose of chemotherapy, and the cyclophosphamide, the CYC, is the most responsible drug for creating this type of failure, but the total body radiation is definitely the one that is mostly the most gonadotoxic. Now, of the pediatric and the adult survivors of hematopoietic cell transplants, only 4.5% became pregnant. So if you don't do a type of fertility preservation, these patients are going to survive, but they are going to be infertile. And so for the rest of the patients. But really what is difficult, really difficult for us is when we are asked, can you give me an opinion? What do you think the risk of becoming menopausal if I'm treating my patients? These are the oncologists that they call and say, if I give to this patient this type of a protocol, can you tell me what's the chance that she's going to become a menopausal? I don't know. I don't know. Maybe it's little. Maybe it's very little. But because I don't know doesn't mean that you should not talk and discuss with the patients about fertility preservation. So because we really don't know, and it's difficult to predict recovery, I'm a strong believer that we should offer at least the opportunity for them to talk to us and do some type of options. Now, the lupus, I told you before, the same medications that are used. I don't know if you have a pointer, but if not, I put it in the circle. So the cyclophosphamide, the methotrexate, so they are all medications that are used for SLE, and especially the cyclophosphamide is gonadotoxic. The beauty today is that the great majority of patients, they are surviving cancer. So that's a remarkable progress. We have now 80 to 85% of patients with the leukemia, lymphomas, that they are survivors. So that's a fantastic achievement. And having said that means that if they survive, you don't want them to remember as a survivor that they one time had the cancer. Because if they cannot have a baby, that's the only thing that they will remember. I cannot have a family because I was treated for cancer, I survived the cancer, but now I still remember cancer every single time I see that I cannot have a baby. So we need to do something because the survival is excellent. So where to look for referrals? We have to talk with our colleague GYN oncologists, but we also have to talk mostly with adult and pediatric hem-oncologists. We need to have a great collaboration with our colleagues, breast surgeons and oncologists, surgical oncologists. We need to talk with the adult and child neurologists because we do see cases of brain cancer, and they need to be also offered the opportunity for fertility preservation. Because of the rheumatological disease, we need to establish collaboration and talk with the adult and pediatric rheumatology. The youngest patient that I froze eggs is a 14 years old that was affected by SLE. They came from a pediatric rheumatologist. So before she underwent to treatment for it, so she froze eggs. She had puberty at age 12. And then internal medicine and transplant medicine. So these are really the place where we should establish a great network of collaborations. So these are the drugs that are at risk, but as I told you before, when the colleagues ask, what do you think is the risk? Really cannot really say too much, except if it's a high risk, everybody knows, cyclophosphamide, procarbazine. Then we have the intermediate risk. But then there are those at unknown risk, which are the oxaliplatin, the irinotecan, which sometimes in cocktail for young patients with the colon cancer. So we should offer in the uncertainty of giving an answer. Because then you may have the risk of infertility, which is a high risk. More than 80% of patients having that particular cocktail of chemotherapy will develop ovarian insufficiency. Intermediate risk, low risk, and then the unknown risks. So we published the guidelines, we tried to sensitize the colleague oncologists. So in order to achieve referrals, in the first guideline we published were in 2006, and that was a great game changers, because now the oncologists had no more reason to say, oh, I did not know about it. Well, now you know. So since 2006, the ASCO, the American Society of Clinical Oncology, allowed us to publish the first guidelines. They were updated in 2013. We published in many journals other recommendations. So really there is no reason now for an oncologist to say, oh, I did not know that there are options. But still, even there are guidelines. Look at this beautiful pyramid. This is the number of patients that they get an insult, gonotoxicity by chemo or radiotherapy. These are the number of patients, the FFC, that fertility preservation counseling, so you already lose a lot. And then on the top, the tip are those, they do something about it. See how many patients we lose. Now why? What are the barriers? One, okay, still lack of awareness, both doctors and patients. So now we are acting on patients, you will see at the end. We are really trying to convince our customer that this is what they should tell to the oncologist, if the oncologist does not talk about it. Then the second point is the provider bias, the doctors, the colleagues. The patient has already had the children, so they don't need more kids. Really? What if this patient was your daughter, or is that really the assumption that the patient is having, or is your assumption? Our patient cannot afford it. Or really based on what? So these are really the reason. The things that are on the right side are things that we put together as our own experience at Yale on what type of answer we receive from some of the colleagues, and they are all there. Oh, there is not just enough time. Maybe the fertility preservation strategy may make the prognosis for the cancer even worse. The availability and access of the services, I don't know where to send it. Well, you know where to send it. We are right here. Or it's really feasible. So really, here in the slides, what are these barriers? Educational, the cost, because unfortunately it's still not covered by insurance, and they can become costly. There are still some barriers on religious and ethical grounds. There are patients that they don't want to have the opportunity of freezing, and then they are afraid that maybe if they die, they leave embryos that, oh my God, I'm leaving embryos behind. Well, but you can freeze the eggs. Today, the egg vitrification is fantastic. But really what I think is important is to convince. So colleagues must buy in. We really need to have a partnership. We cannot do it on your end by yourself, or on our end by yourself, or the patient by themselves. We all need to talk the same talk and walk the same walk. And the most important for the United States is also the geographical barriers. If you look at the place where the IVF clinics are, where this fertility preservation should take place, look at the entire map of the United States. And there are a concentration of clinics in the northeast corridor. Here is the area of New York. A concentration of a clinic in the West Coast, on the California side. But look in the center of the country. There are states with only one center or no centers. And those are the centers where, we really need to come up with some solution, we as a reproductive endocrinologists, to help patients also in those areas. Now, if you look at, when I say what's the magnitude of the problem, let's look at this from another angle. Let's look at the National Cancer Institute's centers. So these are centers, they work under the label of a National Cancer Institute. And there are 369 centers in the United States. They see about 250,000 new patients a year that they get a diagnosis of cancer in one of these NCI. And the question is that they treat a lot of these patients, and we don't know how many are really referred, and probably very, very few of these. So you see there is a recruitment area, NCI centers, but they are disconnected with the fertility preservation centers, and we need to put the bridge there. Let's look at some examples. in Connecticut, where I work, Yale has a cancer center that is an NCI center called the Smilow Cancer Center. But in Massachusetts, you have the Dana-Farber, Harvard, New York, Memorial Sloan Kettering. All these are all cancer centers. Now, of course, in the big city, you have the connection. At Yale, with the Smilow Center, I do have the connection. That's my beautiful center here, not mine, but it's the Yale Smilow Center. It's called Smilow because, in parentheses, the Smilow family donated $300 million, and they made the center. So, and they got the name, Smilow. 1 year and came up out of the blue from one of the geographical area of the Yale campus. So the beautiful Smilow Cancer Center sees a lot of patients every year. So we looked at how many they see in the age bracket of 0 to 9, 10 to 19, 20 to 29. For us, the ones that are of more interest are all the way up to the age of 40. And you see that there is between male and female by year, that there is a significant number of patients in the reproductive age group. So then what we did, and this is a work of my third-year fellow, Dr. Duke, she looked at the dispensary of cyclophosphamide, okay? She went to the pharmacy of the Smilow Cancer Center and said, okay, how many prescriptions of cyclophosphamide have you written in the years of exam, and in what age group? And then we wanted to compare the prescription of cyclophosphamide with the referral that were done to us as a Yale Fertility Preservation Center and see what's the percent of patients that we are seeing, how many are we losing. And you see here that there were 54 patients in this just 1 year of observation between the age of 12 and 41, and only 9% were referred to us. So we really lose from within. And you see that of this 9% that were referred, the great majority were referred 2 days after they already started the cyclophosphamide, which is really a very poor. So I was shocked when I saw the data. I said, oh my goodness, we spend so much time in talking to the colleagues. We do outreach. We are right here. You don't need to go anywhere. We are right here. We are 3 kilometers apart, the Smilow Center and the Yale Fertility Center. I mean, what's going on? So, and therefore, we have to do something. Okay, so let's rearrange ourselves. So we made some educational pamphlet for physicians and for patients. This is the one of the pamphlet, which is the Yale embryo egg sperm saving process. Yes, you can become still a parent after cancer. This was a drawing that my daughter did, my daughter Rebecca, thinking, okay, Papa, I can do the test tubes, and the people can save eggs or sperm, and then they can have a baby in the future. So that's one. Second, we start to create, we need to sensitize our team. All right, so the oncologists need to be aware of the fertility preservation option. I need to have all the reproductive endocrinologists of the team be aware, because it's a 24 hours a day, 7 days a week service. You need to be really dedicated to this type of operations. Therefore, the fellows, young attendings, they all need to be part of this. You need to have an RN, a registered nurse coordinating the care, social worker, because they need to be having some type of counseling, right? It's a very traumatic experience. And then you have to teach and train your laboratory personnel, because you may ask to do ovarian tissue freezing, for example, and you cannot say, oh, I've never done it before. So everything has to be available if you open a center of fertility preservation. So the way that start, the steps, the oncology starts the referral. The reproductive endocrinologist sees the patient max 2 days, 48 hours, from the moment that the referral is made to the moment the patient walks into your office. And then we make plan for fertility preservation, and these are communicated to the oncologist that is referring to us. One of the beauties that having an electronic medical records, which we co-share in the system, in the Yale Health system, it allows me to read what the oncologist wrote, and the oncologist can read what I'm writing after I see the patient. And then we have financial, because you need to have people that talk right there whether there is any help for their case, some money, pharmacy can provide the fertility drugs for free. There are compassionate systems in place. At the same time that they come in the clinic and nurses are already teaching what type of protocols you need to use. Today, as you know, you don't need to wait for the menstrual cycle. You can start the stimulation any time you have to. So that 6 weeks from the moment of the diagnosis to the moment that you can harvest eggs is now reduced to merely 2 weeks. No more than that. So you can do this really, really fast. Now, but still, if I'm losing referrals, and I showed it to you because the referral system is very little, what else can I do to improve my gathering of patients? So that's the solution, or one of the solutions. Because we talk via electronic medical records, what we can do is to put what we call it EPIC stop. EPIC is the program that we use as electronic medical records. We use an EPIC system. Now, in the EPIC, when the oncologist is seeing a patient that is in the reproductive age, before he or she can close the chart, okay, before you say, okay, conclusion of the chart, something pops up that does not allow the chart to be closed. And the reason why something pops up is because, okay, did you ask, which is a fertility preservation, did you talk about fertility preservation, yes or no, patient interested, yes or no, if yes, did you make a referral? So this is something that I think will allow us to start to, in an intelligent manner, without putting pressure too much in the system, not too much more resources, just put it in the computer. When they want to close the chart to get their money, they cannot close the chart if they don't answer, did you talk about fertility preservation? We had the same system when we had the Ebola virus scare. Because there are many patients that they travel from outside the United States, before I can close the chart, I need to ask, are you coming from an Ebola infected area? Now we are going to do the same with the Zika virus, the same stop for smoking, did you ask smoking cessation and so forth. So we are using the electronic medical records. And then at the steps 2, 3, and 4, when all of this has been done, so you really, you can do in 2 to 3 weeks maximum, the process is completed. What we discuss are the options that are here. Some are established, oocyte freezing, embryo freezing, it's no longer experimental, but the ovarian tissue freezing and future regrafting or transplantation is still experimental, which means you have to be prepared. I don't know in a private practice, but in a university, we need to be prepared to have a protocol, which is an IRB-approved protocol for ovarian tissue freezing. I cannot just do it and charge. In fact, I don't even charge when I do ovarian tissue freezing. And now we are only doing the cortical strips and no more the entire ovary like we were doing before. So then the patient asks, but is it safe to freeze eggs in a cancer patient? How many babies have been born from egg freezing in cancer patients? No donor eggs, no infertile patients, just cancer patients. There's not too much data on that. These are probably 7 or 8 babies so far born by using egg freezing. So the great majority of eggs that have been frozen in cancer patients are probably seen in liquid nitrogen. And the data are now starting to be accumulating. But this is one of the latest report. For the embryo, we are not freezing anymore at 2 p.m. We are not freezing at day 3 embryos. We are only freezing at the blastocyst, but that's our choice. So when I talk to a patient that is interested in embryo freezing, I tell them, if the embryo does not make it to blastocyst, there is going to be no freezing, because I don't like to freeze illusions. That's what I say to them. I don't like to freeze illusions. And then they understand. So there is a chance that the patient may have only 2 or 3 embryos on 2 or 3 PN, may have 2 or 3 cleaved embryos and then end up with 0 embryo, blastocyst, or only 1 blastocyst. Then she may do quickly another cycle. But you need to have a very good degree of confidence, of course, in your lab, and I'm giving this as a given that you have that your lab is a fantastic embryo lab. For breast cancer, the protocol that we use, like probably you do too, is the letrozole, the aromatase inhibitor, with the small amount of FSH and GnRH antagonist. I want to show you this a couple of papers that were from a year and a half ago, because sometimes the oncologists ask you, but is it okay to do an egg freezing or embryo freezing after I do already a tumor resection, or you need to do it before I do the surgery? Well, there is really no difference. The outcomes are not different whether the patient had the controlled ovarian stimulation before or after ovarian breast resection. The same, you see the difference in survival between patients that had the ovarian stimulation and controls that did not. There's really no difference in the recurrence. 4% recurrence of breast cancer in the ovarian stimulation group, 4.7% in the control group. And here is also important, these slides. In this work, you see that whether the estrogen receptor negative or estrogen receptor positive group, okay, there is really no difference in survival and recurrence rate. But this is an important information for our when we talk with our breast surgeon colleagues. For the ovarian tissue cryopreservation, it's an option that is not so often practiced, but there are patients now that they are starting to understand that if you freeze eggs, how many eggs can you freeze? And I come up with a number. Hopefully, you can freeze 8 to 10 eggs. Would that be enough, doctor, for me to have 2 or 3 kids? The answer is no, because with the 10 eggs frozen, I don't think that you will be enough. Well, but now I need to be treated for cancer. I don't have the time to do multiple treatment. So then you can say, well, maybe what we can do is we can do a ovarian cortical strip freezing. So let's do 1 cycle first, and then when you recover it from the cycle, because you cannot do ovarian cortical strip after you stimulate the ovaries. The strips are very, very thin, and it's dangerous. So you wait 1 cycle, and then you do an ovarian cortical strip. But you also need to make sure, if you offer these options, that the type of a cancer is not a cancer that has a tendency to metastasize to the ovarian tissue. Otherwise, you are going to reseed cancer the moment that you want to do a retransplant. Many babies have been born. Many techniques have been described on how to do the regrafting, starting from Donné, then going to marrow, putting back into the ovarian scaffold. And it does work. Well, these are some of the latest data. There are 60 plus babies that have been born. In this attempt of calculating the success rate of ovarian tissue grafting, the success rate was 25% of women, 80 that got the transplant, 20 conceived and gave a live birth. So it's about 25%. Because the patient asks you, so what's the chance of having a baby if I do ovarian tissue freezing? That's what we are quoting. And it's also possible to do an ovarian tissue freezing during childhood and then a retransplant after the patient has become menopausal after puberty. And that's the very first report of an autograft of ovarian tissue that was cryopreserved during childhood from Isabelle de Mestier. So in summary, decision 3, if you want to do ovarian tissue freezing, ovarian involvement is unlikely. You can offer ovarian cryo if that's what they want to do for more eggs after you do an ovarian stimulation. If the ovarian involvement is likely, you can still do ovarian tissue freezing, but then it's dangerous to put back the tissue. And we are working, so others, in vitro folliculogenesis. I cannot tell you yet too much data on that, but I'm also working with our colleagues in Sweden, with Mats Brandstrom and Milan Milankovic, and we are now using ovarian perfusion in vitro and see whether we can have a folliculogenesis in these bioreactors. And we are giving FSH to ovaries that are kept alive for 2 or 3 days, 4 days. So still too early, but that's where I'm going with my research now. So in summary, we must remove the barriers to access fertility preservation. We need to educate doctors. We need to educate the staff. but most importantly, the patients. We need to reduce economical burden, has to be much more affordable. We need to really convince the colleagues that this is the right thing to do. So they really need, we need to have them to buy in what we are trying to do. I believe the last point is the most important one, which is the collaboration with the patient advocacy group. They are really, that's the best voice. The best way to propagate the message is really to go hand to hand with patients. They are the ones that are the game changers. They are the ones that are the only direct interest in this, and they are able to move it to fruition. So collaboration with the patient advocacy group, I believe, is the best way to get things done. And the final slide. So how to set up the center? So first you evaluate the resources that are available for the doctors and for the patient. You need to provide the staff with the continuing education on fertility preservation option. But the first thing is do a little assessment of your place. Do I have a space available? Do I have interest? Do I have colleagues that are doing cancer that they will be willing to help me? So you do the needs assessment. You want to know the volume, because you need to do a small business plan when you are trying to do these things. Patient volume. Are there any barriers that you need to overcome to gain the interest and the support of the people that are in charge of the various structures? The formal relationship between REI specialists and cancer care providers, that's key. And then start the program. Start the program, learn on the way on few things that you want to change, fertility preservation, ongoing cancer care. But you also need to continuously assess if there is room for improvement. Like in any other type of activity, fertility preservation is no different. You need to be sure that you are doing the best thing for the patients, and you can always keep improving it. And this is really my last slides, that we work with the patient advocacy group. There are so many. You go on the internet, on Google, and you type in, many show up. But the ones that are most organized, the first one is Stupid Cancer, stupidcancer.org, fertileaction.org, and the Alliance for Fertility Preservation.org. So these are the ones that we really collaborate, give talks, do educational material, outreach with them, and has been so far paying some dividends. And the last slide is the colleagues that helped me to put together the talk. And if you are interested and you want to know more about what Nico said before, that I'm the president of the International Society of Fertility Preservation. So if you want to become a member, we welcome all of you, and the www.isfpfertility.org. And that's all what I have to say. Eucharisto, and again, thank you for having me here.